prior exams that will make the exam itself a little bit more tolerable. And is there any, and what language do you use to describe your anatomy? And this is where patients, I will tell you, 9 out of 10 times patients are like normal anatomic language. Or if they look at me like, what is she saying? I will say, is normal anatomic language acceptable? And also it is actually saying it the first time, it comes out a little bit awkward. And sometimes I'll say, I know that sounded really awkward. What I meant is normal anatomic language okay? And they will say, absolutely. So, and also keeping in mind, if someone comes to you and you can tell they feel awkward about where they are in terms of their gender identity, keeping in mind that everyone is on this continuum, a lot of patients are in this continuum or in this spectrum or in this evolution of where they are in this gender affirmation, their transition, their expression of in this of where they are. And so some patients who are in this evolution, they may be just at the beginning of thinking about hormone therapy, or they're well into it, a couple of years, or they're really into it. They've been it on for 10 years and not even thinking about getting pregnant, or now menopausal and thinking, will I continue this? Okay. And so this also, the gender affirming treatment, what we talked about, hormones versus surgery, there's a whole lot out there. And hormone therapy, when we talk about estrogen, if you're trying to feminize your external appearance versus masculinize your external appearance. And I will tell you, I do think testosterone is incredibly powerful. Surgery wise, again, breast augmentation, chest reconstruction, all of those things are possible. Next slide. When we talk about hormones, the goal of gender affirming hormone therapy is to induce those physical changes to match gender identity and then to maintain hormone levels in the normal physiologic range for target gender. So for next slide, for testosterone, really what we're trying to do is get hormone levels in assigned females at birth to testosterone levels of about 300 to 1,000. 1,000 is pretty high. And you think about your patients who have PCOS, probably the highest you've seen is about 100, right? And even at 100, you'd be thinking, is there a testosterone producing ovarian hormone? So we're talking about a really high testosterone level. And then over 1,000, and even I would argue at 800, remember that testosterone can start to be aromatized into estrogen. Okay. So we're talking about getting testosterone levels pretty high. So this slide and the next slide, what you see in red is permanent changes. So clitoral enlargement, deepening of the voice, and the hair growth. And that's why the participant who said your friend still has the hair growth is permanent. Okay. The increased muscle mass and the coarser skin. Remember that testosterone is also anabolic. Okay. So not only is testosterone androgenic, so you get the increased hair growth and also remember that you can get male pattern baldness, but you get acne, but you also get anabolic effects of testosterone. And so also keep in mind when you have patients who say, I have pelvic pain, which is very common, you're also talking about increased muscle mass and still a female skeleton. So a lot of times you will potentially have pelvic pain that is probably of a musculoskeletal etiology in trans men. Okay. The weakening of tendons is not so clear. This slide is just really quickly to talk about the different types of testosterone, whether it's injections, intra-subcutaneous, which is Texapel, or the transdermal. Transdermal is pretty quick acting, but it gets your testosterone levels pretty high. The tough thing is about it is there's transference. Okay, next slide. And then what we talk for, preconception counseling. I would say this is the same for all of your patients. The biggest thing is just the medication review about testosterone and then the natal sex organ screening. The medication review. So what we're talking about is if you should stop testosterone. So most patients are doing the transdermal or the injection. The injection is either a weekly or every 3 months. Testosterone has a decently fast half-life. So most patients who are doing weekly injections, if they miss a dose, like their weekly dose, it starts to drop pretty quickly. And in our next couple of slides, some of the literature suggests that um, patients will start to cycle, so have the return of their monthly bleeding within 3 months of stopping their injections. So family forming options. How do you build a family if you're a trans man and or do not have access to sperm? So adoption and foster care, definitely out there. Conception through home insemination or assisted reproductive technology. Next slide. Alternative insemination. So basically, we're talking about IUI. So intrauterine insemination. You could also do intracervical. So typically, it's done with frozen sperm, whether it's a donated or direct known donor. You typically current guidelines for office insemination is prohibits fresh sperm because of the risk of infection. But you could do a natural, so as long as you can document ovulation versus a medication like letrozole or Clomid. Usually home is going to be fresh sperm. If it's in the office or fertility center, there's limited insurance coverage, and it all depends on how your insurance is going to define infertility or social infertility. Thinking about our case, again, you have two people who have two uteri and two sets of ovaries, but no sperm. Surrogacy is also a very important option, although it's expensive and it's also very much state dependent. I don't know South Carolina's laws on surrogacy and what if it's covered. Usually, surrogacy is a gestational surrogacy where you have an egg donor and then you have either a donor sperm or a partner sperm. And obviously, there's a lot of legal involvement. Next slide. And then fertility preservation and or IVF. All of this is done through your IVF, through your reproductive specialist. So patients, if you have a partner who is a trans woman, talking about freezing sperm before they start estrogen therapy, you can do testicular sperm extraction. And if you are a trans man, before starting testosterone, doing egg freezing or cryopreservation, which would include them stopping testosterone and then doing an ultrasound guided retrieval of eggs. Ovarian tissue cryopreservation is no longer considered experimental. Here in Boston, they do it. And then embryo banking. So it goes one step further than just freezing eggs. It's forming the embryo immediately right after removing the eggs with either chosen donor sperm or a known donor. Next. Next slide. And then this is just a quick one about semen parameters among transgender women. So again, assigned male at birth who use estrogen. And it looks at, next slide, doing a semen analysis, both in persons who used estrogen, those who did not use estrogen. And the take-home point is really if you leave a semen sample while using estrogen, you have lower semen concentration, lower sperm motility, lower total sperm count, and less sperm stored. So basically, bank your sperm before using estrogen therapy. So all trans women should bank their sperm before. Now, this is the flip of that. For trans men, what are the outcomes for using for egg preservation? And this was done in Boston, 2019. Next slide. And basically, it says that more eggs were actually retrieved in transgender cycles than cisgender cycles, although they used higher doses of medications. All of the trans men actually stopped their testosterone level. All of them stopped their testosterone prior to having these embryos or their egg cycles. But again, if you are a trans man, you don't want to be off your testosterone that long. and you don't want to do multiple egg retrievals. So it is encouraging that you could do one cycle of egg retrievals and get as many eggs as you possibly can. And when they looked at the pregnancy outcomes, they were also the same and favorable. So the prior use of testosterone does not seem to have a negative effect on ovarian stimulation. Next slide. And so this is an old study as well, back in 2014. So pregnancy in trans men and what was the experience? Next slide. So this was a retrospective, again, online survey. I looked at 41 trans men who identified as transgender before they actually got pregnant. And of the 41 trans men, 25 of them used testosterone before they got pregnant. Within 6 months, 20 of men had return of their menses after stopping testosterone. I think the biggest thing is a third of these pregnancies were unplanned. And so that's a really, really big take home point about contraception, which we'll talk about in 2 weeks. But the majority of these men use their own eggs. So next slide. So the pregnancy experience incredibly varied. Some felt isolated, but some of them also felt like they were relieved. Next slide. And the pregnancy outcomes were otherwise were similar. So no difference in pregnancy outcomes. And next slide. So the recommendations, the second paper was actually from the same group of authors. And go ahead and basically the recommendations were that really these men, really what they wanted before they got pregnant was guidance from their providers to know what to expect, to know what the testosterone was going to do to their fertility, what to expect. They kind of wanted to know the logistics of when I start my testosterone, when do I stop my testosterone, and what to expect, what type of resources would I have afterwards. Who was going to, if my partner also had a uterus, where would I get sperm? How would I get sperm? And really, they just wanted that guidance. Next slide. And you can go through that. And this I also put in just as something to think about is chest feeding. When we talk about gender affirming surgery, about top surgery where the lactating tissue is removed, thinking about infant feeding choices in trans men and about asking about future surgery or intended future surgery, but asking patients about, if you have thinking about top surgery and future children, have you thought about how you would like to feed your child if you were thinking about having chest feeding? It is possible. It is very difficult, obviously, if you have top surgery. Next slide. The legal considerations are huge. It is something for if you have a patient that is talking about using donor sperm, if you are using fresh known donor sperm, it is also very important because genetic parents have legal relationships to child at birth. So you need to have contracts when using donors and surrogates. If you are adopting and you are in a same-sex marriage, adoptions and surrogacy have very different laws in different states, depending on the states where you're at. So the Family Equality Council is an excellent website. And then the price of parenthood. I know looking at these numbers is very disheartening, but it is quite expensive, and you need to be thinking about the price of donor sperm. I think most people are pretty surprised when you look at a vial of sperm for an anonymous donor sperm. It can range anywhere from $300 to $1,500 a vial. And you think about, usually it's one vial per insemination, and it's quite expensive. And then surrogacy and obviously IVF is quite expensive. So there is a lot of planning. Next slide. So going back to our case, what happened to this couple? Next. They had a IUI with a fresh donor sperm. They joined and got pregnant, had a beautiful vaginal birth. They joined a support group during pregnancy that was supported. It was a support group actually through Fenway Health. And the trans man chest fed the baby for a full year, went back on testosterone after a year, and they were thinking about another family. So take home points, just over, I know we went quick, was provider education and system changes, improves care for our patients, staying focused, remembering that the same health issues that impact cisgender health impact transgender health, and then routinely discussing family building options and fertility preservation for patients who identify as gender diverse. Thank you. And any questions that you have, I'm happy to answer. And any comments